any angiograms in my talk today, so it'll be a little bit of a different spin. These are my disclosures. I am a consultant for 2 companies, and I'll show you some of the consulting work we're doing, trying to get a few new drugs from the drug companies to be studied in children with heart failure. My outline will be to talk first about adult heart failure guidelines. I'll talk a little bit about the epidemiology or incidence and cost of pediatric heart failure. I'll talk then about the pediatric heart failure guidelines. There's a new group of guidelines that just came out from the International Society of Heart and Lung Transplant. I will talk about a few new drugs that are coming down the pipeline that Dr. Berger has been involved with as well. I will talk about mechanical circulatory support, and I'll end with my thoughts on how to structure a pediatric heart failure program. So let's just start with heart failure. As we all know, it's some type of problem that occurs with the heart, resulting in decreased cardiac output and often decreased blood pressure. That leads to a cascade of decreased organ perfusion, elevated heart rate, tachypnea, diaphoresis, exertional dyspnea, fatigue, exercise intolerance, and then this huge compensatory cascade takes place with neurohormonal activation, with increased epinephrine and norepinephrine levels, increased renin, increased aldosterone, antidiuretic hormones, and this initial compensation allows to retain output by increasing afterload. Then this goes on to what we call adverse left ventricular remodeling and all the things that happen with that. You have a preload that goes up. You then have increase in wall tension. You have an increased volume or ventricular dilatation that ultimately can result in worsening of cardiac function with oxygen demand increasing. And then these are the signs we all see with right-sided heart failure with congestion, left-sided heart failure with congestion, and this vicious cycle is now into place because now we have worse cardiac output and more problems. So we try to intervene with this. We use ACE inhibitors to block the conversion of angiotensin 1 to 2. If ACE inhibitors are intolerant, then we go to angiotensin receptor blockers, which will block the actual the receptor where angiotensin will attach. We also have aldosterone antagonists or mineralocorticoid receptor antagonists, which hit a different part of this neurohormonal cascade. We all know beta blockers, and I'll talk a little bit more about that. That came later into this picture, but clearly is important in blocking the sympathetic nervous system. Diuretics and Lasix, particularly Lasix, is the mainstay of therapy in adults with heart failure. And then we mustn't forget inotropes, including digoxin, although there never has been an inotrope in a stable patient that has improved survival, including digoxin in patients with heart failure. So these are the drugs that we have. We also have access to other drugs that may help with arrhythmias, antiplatelets, anticoagulants, and other non-pharmacologic treatments. So this is currently the treatment regimen that we have access to and really have not had much new in this area in over 20 years. So I will comment on that, and that to me is what's so exciting about these new drugs that we hopefully will have access to. So we'll start with what's known about the recommendation for treatment of adults. And this really comes from an article that now is a couple years old, published in Circulation. And they talk about 4 stages of heart failure. Stage A is when one's at risk for heart failure. Stage B is when there's structural heart disease, meaning in adults, left ventricular dysfunction generally, without signs or symptoms. Stage C is where there's structural heart disease with either previous or current symptoms, and stage D is refractory heart disease requiring special interventions. And these are the current recommendations for stage B, heart disease without signs or symptoms. So these are the kids in our practice who would come in with left ventricular dysfunction, say, but they're asymptomatic. In adults, the class 1 indications are ACE inhibitors, to be used in patients with reduced ejection fraction to prevent heart failure. And this is actually level of evidence A, meaning multiple prospective randomized trials. Then there's also class 1 indication for beta blockers should be used in patients with reduced ejection fraction to prevent heart failure, but the level of evidence is C. There is not really good data to support that. This data for the ACE inhibitors was proven many, many years ago in a prevention trial, the SOLVE prevention trial. Notice there's also class 3 recommendations, meaning that certain treatments will either cause harm or have absolutely no benefit. And in this, for instance, are calcium channel blockers that could be harmful to patients with heart failure due to reduced ejection fraction. Now, once one becomes stage C heart failure, remember that is current or previous symptoms, everything changes. And this is that heart failure with reduced ejection fraction, HFrEF as we call it. Class 1 indications, meaning indicated in everyone, level of evidence A, multiple prospective randomized trials, ACE inhibitors or angiotensin receptor blockers if intolerant, and then beta blockers. So everybody should be getting those who have systemic left ventricular dysfunction in adults because of heart failure with reduced ejection fraction. In addition to that, in adults, for all patients with volume overload, you need to add diuretics. And there's a class 1 indication, but level of evidence C. There really is no good prospective randomized trial because everyone is confident that in patients who are fluid overloaded with heart failure, diuretics are a benefit and needed. In African Americans and adults, they recommend using hydralazine and nitrates. That comes from the AHEF trial from many, many years ago. And then for those who have persistent symptoms or class 2 to 4 symptoms with acceptable renal function, use of mineralocorticoid receptor antagonists, aldosterone antagonists, aldactone, or eplerenone are indicated. Level of class 1 recommendation, level of evidence A. Also within stage C, there are some other recommendations. So digoxin has not gone away totally. There have been times when I thought we'd never see digoxin in heart failure again, but it is around, but it's a level 2A indication, meaning that it's unclear how beneficial it is, but the evidence is in favor of its use. In contrast, other drugs will be 2B, meaning they're not, the level of evidence points away from them being beneficial. With regard to anticoagulation, I was really quite surprised to see that they were unable to make a statement. They just said that it has to be individualized, which means that they don't know. The committee had no idea what guidelines to provide, but they do not routinely recommend using anticoagulation in heart failure. And in fact, they thought that anticoagulation is not recommended in patients with chronic HFrEF without atrial fibrillation, a prior thromboembolic event, or a cardiogenic source. So they believe that it's not indicated unless you're in atrial fibrillation, had a previous thromboembolic event, or have a clot in your heart. Now, stage D is when we get to refractory heart disease requiring special interventions. And the recommendations in adults, they talk about inotropic therapy, mechanical circulatory support, and heart transplantation. But actually, the only class 1 indication in stage D heart failure in adults is diuretics. So patients are managed with diuretics. In the large adult trials where inotropes were added, such as milrinone, outcomes were actually worse. So their only class 1 recommendation here is going to be diuretics. And then the class 2A recommendation really is just more diuretics, either increase it or add another one. Now you get into other things. Class 2B, you can see, is dopamine infusion may help to improve diuresis. Ultrafiltration, something we really don't use in kids routinely. Nitroglycerin, nitroprusside, nasiratide, again a 2B. And then possibly vasopressin antagonist if there's hyponatremia present. You can see there's really no talk here about using things like dobutamine, dopamine, epinephrine, or even milrinone. Now, I'll briefly talk about electrical therapy because we do still use that, and I'll show some data that, as skeptical as I have been of this, I think there are some indications. In adults, the indications, the class 1 indications here in green are very clear. To have symptoms, you need to have symptoms, have an EF less than 35, a prolonged QRS, a left bundle branch block pattern, and sinus rhythm. Those are the indications. Those are the only class 1 indications. Now, these are things we see very rarely in children. Rarely do we see a left bundle branch block pattern with a QRS prolonged like this. It happens, but in less than 10%, maybe 5% or less. And the class 3 recommendations, meaning one should never consider it in this setting, are those who have a normal QRS duration and not a left bundle branch block pattern, which represents the majority of our patients, except those who have a right bundle branch block, which is rare in adults compared to what we see in children. So those are the adult recommendations. So let's move on to what we do with our children. I'll first talk about sort of the epidemiology. So this is work from Joe Rossano from our institution, and a few years ago, he published this data, which was taken from a large, that's called the FIS database in the US, which is a large administrative database of over 40 hospitals, children's hospitals in the US that submit data to this. And what he did is he looked at when a patient was classified as having heart failure during a hospitalization, how has that changed over the years? And as you can see here, when someone admitted with heart failure had a certain incidence years ago that has now increased both in the total number of admissions and admissions per 100,000 children. So the incidence of heart failure is going up. And this is from 2006, and we only believe that this has increased since that time. And not only has the number gone up, but the costs have gone up. These are the mean hospital charges for children admitted with heart failure, and these are the total hospital charges in billions of US dollars. And as you can see, these costs have virtually doubled between 2000 and 2006, and at this point are continuing to go up. These are very expensive hospitalizations. And they've increased in adults as well. If the white down here is adult costs of an adult heart failure hospitalization, but as you can see, the change in the adult heart failure hospitalization was quite modest over that time period between 2000 and 2009 compared to that in children, which has increased enormously. And I believe these costs are just going to continue to increase, which has put an enormous burden on the healthcare system in the United States as these costs go up and up. Length of hospital stay actually has gone down a little bit in adults over that period of time, from about 7 days maybe to 6. The opposite has happened in children. The average hospital stay is about 15 days, has gone up to about 17, 18 days. And the length of stay is dependent upon how old you are. And as you can see here, these are the children. Every single one of these age groups has a longer hospital stay than any adult age group, including those older than 70. So this is a big problem with these patients being admitted and staying in the hospital a long time, particularly those who are less than 1 year of age. And it's a high-risk group. Hospital mortality is a big problem with this group. And although hospital mortality has decreased in children and in adults, it is still significantly higher than in adults. Adult heart failure mortality during a hospitalization is gone from about 7% to 5%, whereas in our kids, it's gone from about 9% down to about 7%. So it is still higher than adults. It's a high-risk group. And this group is particularly high in the newborn and infant period, and actually all children have a higher mortality, except for the teenagers, than any of the adult age groups. So this is a high-risk group once you have a diagnosis of heart failure and being in a hospital. And compared to someone who's admitted to the hospital without a diagnosis of heart failure, you have a 7% mortality compared to a 0.4% mortality, which is an odd ratio of 20.6. So you have a 21 times higher chance of dying in the hospital with a diagnosis of heart failure than if you didn't have a diagnosis of heart failure. And this mortality is worsened at 7%, including what I'm talking about here, congenital heart disease, about 7%, but you add sepsis onto this, you got now a 20% mortality. You add cerebrovascular disease, stroke, you now have a 30% almost mortality. Renal failure, you're over 30%, and the mechanical support, 40 to 50%. So you start adding these comorbidities, and the chances of these children getting out of the hospital gets worse and worse. So when we talk about congenital heart disease, this is an increasing population of children with heart failure who we need to take care of. They're in addition to the cardiomyopathies that we see and other things, and the reason being we have such low mortality with surgery. I jokingly say, no one ever dies anymore in surgery. Of course, that's not true, but it's very low mortality. but no one's really cured, and we've seen that over the last 2 days of talks. We can do a lot of things, but these patients are cured. So many or most of these patients ultimately develop heart failure, and as the last question that came up today, we may not see that in our population, but they're seeing it more and more in the adult congenital heart disease population. So this is a big problem. So here's what I'm talking about with heart failure. I'm not talking about the term that heart failure is used with large left-to-right shunts or things of that nature. That may be some type of heart failure. I think of that as pulmonary overcirculation. What I'm talking about is this, when the real-time echocardiogram looks exactly the same as the still frame. That's the kind of heart failure I'm talking about. What I'm going to go over as part of this, and it's coming from a monograph series from the International Society of Heart and Lung Transplant, and these are recommendations for the management of heart failure in children. So I'll start with chronic heart failure. Let's start with stage B. Is this applicable to children? Should children without signs or symptoms be started on medications? Well, it's really unknown. We don't have great data to support that, but you could argue that virtually all of our children with congenital heart disease will meet this criteria. They've had sternotomies, thoracotomies, cardiotomies. They have abnormal ventricular morphology quite frequently, and they often have valve disease. So in those with a systemic left ventricle and asymptomatic ventricular systolic dysfunction, I believe an ACE inhibitor and a beta blocker may be reasonable. And I start all of my patients who have left ventricular systolic dysfunction, even if they're asymptomatic, on an ACE inhibitor. I may not start them on a beta blocker right away. I'll watch them, and if they stabilize and do okay, but I do believe in this, and there's not a lot of data to support it. However, and as I'll show you later, in those whose systemic ventricle is a right ventricle or a single ventricle, we really have no good data to guide us on what to do with these patients. Now we go to stage C. Everything changes. They've either had previous or current symptoms of heart failure. Is this applicable to children, the guidelines in adults? Well, yes, it is. Starting with digoxin, there's really little known about its efficacy in children with heart failure due to systemic ventricular systolic dysfunction. There's conflicting data. Some say it helps, others say it doesn't. I don't use digoxin routinely in everybody with systemic ventricular systolic dysfunction, but it is a good drug and has been shown to be helpful if there are persistent symptoms. But the mainstay of therapy really is going to be ACE inhibitors and beta blockers and mineralocorticoid receptors. And unfortunately, we don't have good data to support the use of any of these drugs, including ACE inhibitors, although we all use them very frequently. And in fact, there's some evidence that it not only may not help, but there's some soft evidence that it may not be good in some patients. So this was a trial now published nearly 20 years ago out of Dallas, where they took a group of stable Fontan patients and put half on enalapril, half on placebo, and their primary endpoint was exercise, and they found no difference. However, the mean percent change in cardiac index from rest to maximal exercise was actually decreased in the enalapril group compared to the placebo group. So the concept that, quote, it can't hurt may not always be correct, and we need to be careful of that. So this is a study I did and published now many years ago, and it actually took about 10 years of my life to do this, as it turns out. But this was a multi-center, randomized, placebo-controlled, double-blind trial of carvedilol in children with heart failure. And in this study, we had 23 centers, enrolled 161 patients over 4 years, and we had 3 groups in this. We had a placebo group, meaning background therapy with ACE inhibitors or digoxin diuretics, and then we had a carvedilol group and had 2 different doses of carvedilol, a lower dose and a higher dose. And for the final endpoint analysis, we combined the 2 groups in the combined carvedilol group, and the primary endpoint was a clinical composite endpoint of you're either worse, you're better, or you're unchanged. And as you can see from this, the 2 groups were identical. About 55% of the patients in the placebo group improved during the study, and about 56% who were given carvedilol improved in the study. So there was absolutely no difference between these groups. However, we did look at each group separately, and if one looked at this is the LV group where we could measure an ejection fraction, again, placebo-controlled and blinded, and the echoes were all blinded. We had a pretty sick group. The average ejection fraction at the start of the trial was about 25%. But in those who got placebo, they had about a change in 9.8 EF units if they got placebo, 11 EF units if they got low-dose carvedilol, and 14 EF units. It didn't quite reach statistical significance, but there was a trend that carvedilol did improve ejection fraction and did decrease, actually, end diastolic dimensions. However, there was a big difference depending on what the morphology of your systemic ventricle was. So of the 116 patients who had a systemic left ventricle, those who were on placebo, about 50% improved in the trial, whereas if you added carvedilol, about 65% improved. Not statistically significantly different. However, the opposite happened in those whose systemic ventricle was not a left ventricle, those who had a right ventricle or a single ventricle. And about 65% of them improved on placebo, background therapy, enalapril, et cetera, but only about 50% improved if they added carvedilol to their regimen, suggesting that your response to therapy may be dependent on the morphology of your ventricle. And this problem has been shown in other studies. This was a study from the Pediatric Heart Network, where they looked at enalapril in infants with single ventricle. And their primary endpoint was actually weight for age Z-score. So they said if somebody's growing, then that's a good sign that they're not potentially in heart failure. We're able to get them to grow. And as you can see, there was absolutely no difference between these two groups at any time point, those who got enalapril and those who got placebo. And there are actually no differences in any biomarkers, echo findings, symptoms, or anything else. So they were unable to demonstrate a benefit here of ACE inhibitors in a group of patients with a single ventricle. And there have been many studies and increasing numbers of studies in adults, unfortunately, showing the same thing, where this study from Hector showed ACE inhibitors did not show any benefit in right ventricular ejection fraction or maximal oxygen consumption. And a study from Annie Dory in Canada with losartan showed no evidence of improvement in exercise capacity or biomarkers in adults with systemic right ventricles. So a few years ago, there was this paper published, which actually shows a little bit of hope that maybe these medications may help. This was a study looking at valsartan on systemic right ventricular function in adults with congenital heart disease and a systemic right ventricle. And there was no difference in the primary endpoint, which was event-free survival. However, they looked at a large number of different treatments, and I'll just show you some of these. Right ventricular ejection fraction, no difference at all. They looked at peak maximal oxygen consumption, no difference. They looked at all quality of life measures, no difference. However, there was some evidence that there was a decrease by MRI in right ventricular volume and mass, and that is what we're trying to do, is to reverse remodel these ventricles. So maybe there is some hope that these drugs may have some benefit. Now, to comment a little bit about what we're talking about in this conference, we talked about pulmonary atresia, and we've talked about some of the problems that can lead to heart failure, such as fistulas. Oh no, I lied. There is actually an angiogram here. Okay. But as we all know, these things can cause problems, and the big problem that they often cause is this diffuse subendocardial necrosis of the left ventricle. So this is a disease that can affect the left ventricle in pulmonary atresia, as we all know, not just the right ventricle. And in this study, they found lots of problems with left ventricles that were quite varied, anything from bicuspid aortic valve to non-compaction and beyond. So this is a group of patients that does have heart failure. And it goes into adults as well. And this was a paper that showed the modes of death of patients with adult congenital heart disease, and pulmonary atresia is clearly one of these, with an 11% all-cause mortality and an average age of 27 years. And if you take all comers with adult congenital heart disease, heart failure is a big cause of death, in addition to sudden death, non-cardiac, perioperative, and other cardiovascular problems. So we have all these medications. We are giving them to our patients. How are we doing with that? Well, I'm concerned that we're not doing as well as we could be. This was a study published now 5 years ago by Paul Cantor when he was in Toronto. And he wanted to look at the impact of changing medical therapy on transplant-free survival. This is in dilated cardiomyopathy. So he looked at a lot of different groups. He looked at the pre-oral maintenance therapy group. He had to go back a long way, but you can see 5-year survival here is about 25%. But he then looked at that, if you just had digoxin and diuretics before ACE inhibitors, before beta blockers, he showed a survival benefit here in the 70% range and was unable to show any improvement of outcomes over 5 years if you added ACE inhibitors or beta blockers. So it's concerning that we're not making the kind of impact that we'd like to make with these medications. So that's why we need new medications. And this is one of the new medications that we are studying and hoping to bring to practice within the next year, at least to pediatric trials. So this is LCZ696, and this is a first-in-class combined drug of an angiotensin receptor blocker and neprilysin inhibitor. And it has two properties, and you know about the angiotensin receptor blocker, blocking the AT1 receptor, but neprilysin is an endonuclear enzyme that reduces the breakdown of BNP and other metabolites, and this theory was that by doing this and other metabolites as well, that this will improve outcomes in patients with heart failure. And the landmark trial that showed this is the Paradigm trial, the Paradigm heart failure study, and they had a run-in period to make sure patients tolerated it. And what they did then is they randomized patients to either enalapril or to LCZ and followed them over about a 3.5 to 4 year period. And the outcomes were presented at the European Society of Cardiology meetings in Barcelona in August, and these were the outcomes. If you look at the primary endpoint, which was a combination of death from cardiovascular causes or hospitalization for heart failure, that outcome, that primary endpoint, was achieved much higher in the enalapril group than the LCZ group, and it came true for mortality, hospitalizations, and death for all causes. So based on this, a group of us have been working hard with Novartis to come up with a trial, starting with a pharmacokinetic trial, moving on to a randomized trial to see if we can get this drug to be used in children. Now, I'll talk briefly about the Fontan circulation, and Dr. Gavillig showed this slide earlier, and I can only talk briefly about it because I agree with what he said, that this is a separate problem, separate circulation. It's an enormous one, but not one that we could tackle in the time frame that I have here. But in this great paper from Dr. Gavillig, he showed the normal circulation, the shunt circulation, and this is what he showed earlier, this Fontan circulation, which arguably and truly is not the type of circulation that one can apply the medications that we've talked about, even for the systemic ventricle, because of the way that the circulation is structured, so one has to be cautious. When you have a failed Fontan, that can be due to either systemic ventricular dysfunction or Fontan circuit failure, or both. And with systemic venous congestion and low cardiac output, and it requires treatment, if possible, of a systemic ventricular systolic dysfunction, and how to do that is still very unclear. And for the Fontan circuit failure, after one rules out mechanical obstruction, you're left with very few options as far as treating that. And maybe the intervention is what Dr. Gavillig suggested, is we need to do it much earlier. This is work from Professor Berger and his group here, showing that in those patients, when as an adult, that their volumes were, volume indexes were higher, their function was worse, and their maximal workload was worse in that group compared to the pediatric group, and this shows that this is an age-dependent phenomenon. About 5 years ago at the Children's Hospital of Philadelphia, we started a single ventricle survivorship program. We have had a long history there of stage 1 procedures, a lot of work with hypoplastic left heart surgery, and based on this and all the patients we were following, we felt that this would be a good system. It's a multidisciplinary program that includes gastroenterology, endocrinology, pulmonology, and this group meets now once a week and about to go to more frequently in order to get these patients in for a multidisciplinary evaluation. And one of the fruits of this was a study that we published now 4 years ago looking at sildenafil versus placebo on exercise performance in children and young adults. And what we were able to show was a small but significant improvement in echocardiographic parameters of ventricular function and respiratory efficiency. And based on that, we have tried to set up a large multi-center trial, initially with tadalafil, but we could not get this drug from the drug company, so now we're setting it up through the Pediatric Heart Network with udenafil, a new PD inhibitor. And our hypothesis is this. On the red line here, the blue line, there is a predictable and unrelenting decrease in predicted maximal oxygen consumption in patients with the Fontan that starts somewhere in early puberty, in the teenage years, that allows for them to hit a threshold of around 45%, which is usually a threshold of symptomatic and often having to be considered even toward heart transplantation. And we hypothesized, can we show that this drug, which is soon, unfortunately, sildenafil or one of its congeners, is going to start being standard of care before we know whether it has a true benefit. Our hope would be to study this over a period of 1 to 2 years and see if there actually is a reduction in this unrelenting slope of decrease in their functional capacity. The Bosentan paper was published just recently, a few months ago, the TEMPO trial, and they were able to show with Bosentan that there were more patients with the peak VO2 improvement that in those who got Bosentan than those who got placebo. Again, whether this is going to be a long-term benefit or whether this is a short-term benefit that it will not be as important as we'd hoped is yet to be seen. I will mention briefly cardiac resynchronization therapy. This is a therapy that has been around for some years, and some studies have shown some potential benefit from it. However, the only group that they could identify as a responder in this retrospective review were those who had the lowest ejection fraction, were responders compared to those who had a higher ejection fraction. And if you're going to see improvement from resynchronization therapy, it's almost certainly going to be seen early on. If you're not going to see it early on in this paper from Boston, you probably won't see benefit long term. And most of the patients in this study were actually complete heart block patients. But I was actually in a meeting last Sunday in New York where there was some data presented that I was unaware of, looking at new ways of looking at single ventricles with their dysynchrony and ways to resynchronize them. So I've asked my group in Philadelphia to relook at this concept and see if there is a subset of patients that could really benefit from this somewhat invasive therapy. The current recommendations are few. So this is from that guidelines from the ISHLT. It can be used in children with a systemic left ventricle, EF less than 35%, if they have a left bundle branch block with a prolonged QRS, with symptoms and on maximal medical therapy, and that's a class 2 indication, 2A. And it may be considered in children with a systemic right ventricle or single ventricle with similar findings, a bundle branch block, low EF, and symptoms. We do use defibrillators, and I think this paper from Elfie Paul from the Pediatric Cardiomyopathy Registry is the best that I have seen so far in terms of trying to stratify these patients. They looked at all their patients in the registry and looked at what the risk of sudden death might be, and they found 3 predictors. One was a dilated left ventricle with a Z-score greater than 2.6, younger age, less than 14 was their cutoff, and then this ratio of the posterior wall to end diastolic dimension of less than 0.14. And if this is a persistent finding, then they recommended that patients should be considered for an ICD because this was the group that had a 4% incidence of sudden cardiac death. So the recommendations are it can be useful in pediatric patients with unexplained syncope and at least moderate LD dysfunction, and can be considered in patients who have an EF less than 35% who are symptomatic. That's a class 2B indication. So stage D, we've talked about for adults, inotropes, mechanical support, heart transplant, applicable to children? Yes, it is. But the recommendations are really not very helpful. So the class 1 recommendations, these patients should be in an ICU, ideally in a pediatric heart failure center. You should do a heart cath if you suspect ischemia or congenital heart disease without explained cause of the heart failure. Temporary use of IV inotropes in those patients with cardiogenic shock and poor perfusion, ideally not long-term if you can help it. Consider vasodilators in the absence of hypotension, and then, of course, diuretics for fluid overload. That's class 1. Class 2A indications are arterial line, central venous line for both pressure and venous O2 sats, temporary use of IV inotropes in patients with low cardiac output and decreased perfusion. Consider prophylactic anticoagulation with severe cardiac dysfunction, and it's reasonable to use milrinone, dobutamine, dopamine, or low-dose epi, particularly for right heart failure. Now, class 2B, meaning that it's unclear how important and indicated they are, levosimendan, which we don't have access to in the U.S., if unresponsive to other inotropes, NIRS, near-infrared spectroscopy, which we don't use in Philadelphia, routine use of thyroid hormone, and the evidence really does not support the routine use of corticosteroids or IVIG for myocarditis. And then the class 3 recommendations, the things to avoid: routine use of PA catheters, use of IV inotropes in the absence of hypotension, impaired perfusion, low cardiac output, or decreased end organ perfusion, sodium supplementation. So another drug that's come along is relaxin, serelaxin, and this is actually a naturally occurring compound that mediates physiologic hemodynamic adjustments to pregnancy. It increases cardiac output, arterial compliance, glomerular filtration rate, and decreases systemic vascular resistance. It's a vasodilator, anti-inflammatory, and it has other properties as well. And in the large serelaxin, the RELAX acute heart failure trial, they actually showed a significant benefit of serelaxin over placebo in the primary endpoint and all-cause deaths. So the deaths were much lower in the serelaxin group than in the placebo group. And on the basis of this, the FDA in the United States granted breakthrough therapy designation to serelaxin, and as such, it has the potential to be the first treatment breakthrough for acute heart failure patients in 20 years. We were very excited when this came out. Unfortunately, after they reviewed the data, they voted not to approve it and requested another phase 3 trial from Novartis before approving this drug, and this trial will not be done until next year, toward the middle to end of 2016. So we won't know if this drug will ever be approved. But in the meantime, a group of us, some of whom are in this audience, have worked with Novartis to hammer out a trial, starting with a pharmacokinetic trial. And the way this is structured is you take age groups, older kids, school-age kids, infants, and newborns, low dose, then go to high dose. And the first patients, actually enrolled here by Dr. Berger, or some of the first patients enrolled, have completed this, the first 3 patients in this PK trial. And we've now, the safety group met and has recommended proceeding to the next group, which is going to be the low dose younger children and high dose older children. So we hope to complete this over the next several months, and then if the drug is ultimately approved, set up a prospective randomized trial in acute heart failure in ICUs for children. Mechanical support. We all know the indications for this. Patient is listed for heart transplant or presumed to be a potentially acceptable candidate and has demonstrated inotrope dependency and has evidence of compromise to at least one or other organ system, or the patient is in cardiogenic shock or impending cardiogenic shock. And we know that VADs improve survival. So this is from Betsy Bloom now from 8 years ago, showing that of their group, taking all comers, all ages, all VADs, 86% in this group got to transplant. And if you got transplanted with a VAD, your outcomes were identical to those who are status 1 and not on a VAD. So if you can get to transplant on a VAD, your chances of doing well are very good. And this was the landmark Berlin heart trial, where they compared to ECMO. It was the only thing they compared to, and not surprisingly, outcomes were much better with the Berlin heart than it was with the ECMO group. And I want to thank Berlin, I should say, for devising this heart that we use so frequently in the United States. It's really all we have for bridging these children at this time. And again, Dr. Berger has used this device quite extensively and showed in their recent results that 50% of their group, a very high-risk group, can get to transplant. And a small percent, which is encouraging, can actually get explanted. We've yet to explant a Berlin heart, but that's encouraging that that can happen. But still, it's a high-risk group with high mortality. And the highest risk group for bad outcomes, survival without thrombosis, is best in the smaller pump chambers and worse in the higher size pump chambers. And of course, now we're going into the continuous flow VAD era. And the HeartMate was what we had used initially, and now we are using almost exclusively hardware in our patients who are big enough to have this. And as you know, this is an implantable device and one you can actually send patients home with. And if you look at the utilization in the United States, with red being continuous flow intracorporeal devices, all the other devices have virtually gone away, and that has persisted to this date in adults. This group here was one of the first groups to use this device, and they published their data 3 years ago, so they, again, were innovators in use of this kind of support device. Like many places, we have an outpatient VAD program, which requires extensive family education, demonstrate proficiency. We send them out on field trips from the hospital to be sure that they're okay. Say, go away for 4 hours. You can't come back unless there's a problem. Get used to this thing. Frequent clinic visits, including rehab and psychology, and we have a phone that they call into anytime there's a problem, and we just move that phone around between the heart failure program people. And you can do very well with the VAD. It actually doesn't turn your hair colors, but she chose to do that herself. But these kids went home on a VAD, were home for, fortunately, a brief period of time. One of these was on a BiVAD hardware device because the right ventricular dysfunction was so bad, and they both were successfully transplanting and doing very well. So we know there's nomograms for what devices to use. It depends if you're using temporary support or long-term support, and I would add hardware to this right here. But we have lots of different devices. And the last thing I'd just like to mention is that I believe that a major step that we've made at our institution is the way that we handle our programs when it comes to heart failure. For those of us who got into heart failure in the early 90s, many years ago, we really started it as pediatric heart transplant programs. We were a transplant program. We need to start doing transplants. And then we quickly realized if you're a transplant program, you've got to be a heart failure program for 2 reasons. One, you've got to keep these kids alive until they can get transplanted. But number 2, our job as transplant cardiologists is to keep as many people away from transplant as possible. So we started learning all the different ways of treating and diagnosing transplant. Well, in the 2000s, it sort of became apparent, and we started having not necessarily separate services, but really equal ways of thinking about this, that there's heart transplant, but there's also heart failure, and those need to be thought of as just separately. But now, in the 2015 era, I would argue that this is really the structure of a pediatric cardiomyopathy and heart failure program, where you've got a group of physicians, nurses, nurse practitioners, social work, pharmacology, and others who come together, and that feeds into this and works with this program are the heart transplant program, mechanical support, the single ventricle program, familial cardiomyopathy, genetics, oncology, and neuromuscular. And this is the program that how we have structured it now in Philadelphia, and I would recommend all of you to consider as your resources allow. So here's what we have. This is what we have for patients, which I unfortunately feel is somewhat limited and hasn't changed over many years. We have diuretics for fluid overload. We have ACE inhibitors or angiotensin receptor blockers if intolerant, and that's for stage B or C heart failure. Aldosterone antagonists for stage C heart failure. Beta blockers for stage C in those with a systemic left ventricle. It's much less clear what beta blockers do in a systemic right or single ventricle. Low-dose digoxin for persistent stage C heart failure. CRT for those rare ones who meet the criteria, ICDs for those who meet criteria, and then we're left with milrinone with inotropic escalation for stage D heart failure, and then mechanical circulatory support and transplant for end-stage heart failure. I thank you for your attention.